see, or as I'll explain in a minute, weight gain from antipsychotic medications is both extremely common, and I think that the likelihood of weight gain from antipsychotic drugs remains still underestimated. This is particularly the case in the younger you go in age when those medicines are used. So children and adolescents are extraordinarily prone to developing significant weight gain, and the people don't like to gain weight, so they will stop taking these medicines, and then just you lose many opportunities for making things better. So the general strategy for mitigating weight gain risk is to prefer and try to utilize medications with lower weight gain risk. I'll talk about what are called behavioral treatments, essentially diet and exercise. We'll talk about pharmacological adjuncts and monitoring protocols. So the first thing to do actually is to prefer lower weight gain risk medicines, and this ideally includes not using antipsychotic medications if in any way possible, because even the ones that are low tier have side effects. And I emphasize this because I feel like, from my view of the culture, mental illness is increasingly almost synonymous with some sort of medical disease which requires some kind of medical treatment. This is a relatively new and freakish notion in the history of psychological thought, and nonetheless it seems to be dominating, which leads to lots of prescribing. And there are certainly many cases in which an antipsychotic drug can be enormously helpful. There are many cases in which those drugs can probably be avoided, particularly if they don't involve the treatment of primary psychosis. Nonetheless, when those medications are chosen, this is a best guess consensus about drugs that have the highest or the lowest weight gain risk. So top of the list are clozapine, olanzapine, quetiapine. I would actually usually give it 3+, especially if it's used in doses of several hundred milligrams per day. On the lower end risk, you have things like haloperidol, lurasidone, cariprazine. And the important thing to mention is that even though these drugs have, on average, lower risk of weight gain, still you will find that some 5% or 10% of individuals on a medication like lurasidone will gain a lot of weight. So it reduces the probability that weight gain will happen, but if your patient happens to be one of the genetically unlucky ones, they can gain 40 or 100 pounds on a theoretically low risk drug. So nonetheless, choosing ones with the lower odds are probably the better, is a worthwhile strategy. Behavioral treatments, as I said, this boils down to modifying eating behaviors and modifying activity behaviors, so diet and exercise. This is a summary of effect sizes from a meta-analysis paper, and the bottom line on the graph, you see the vertical line, which is at the 0 point. If it is to the left of 0, that favors the impact of diet or exercise programs, and essentially everyone that was almost everyone meta-analyzed finds that there is benefit, so they work. And they usually don't work by just saying, and you should make sure that you eat better and exercise. The strategies are meeting with dietitian, meeting with support group, meeting with physical trainer, actually engaging, setting up a system that will help individuals to learn, demonstrate learning, practice food preparation and meal planning, as well as learn and do and get support for physical exercise, walking and or gym things. So we'll say all the time, and you should be careful not to eat sugary foods and try to increase your activity. That has never been studied. All these things that show efficacy are actually when a systematic approach has been used with usually accountability partners and means for follow-up. So it works, but it has to be actually undertaken seriously and in a broader plan. The other caveat of the good news about behavioral interventions is that there is a bit of a selection bias. Only the people who are willing to consider the idea of engaging in exercise and nutrition programs are the ones that will enroll in such programs. The ones that have no interest are not likely to be there, and you're going to find in practice both of those who have some openness to the idea and those that are just opposed to it. So in clinical practice, you might not see as good results as the literature would lead to believe, because you don't have the benefit of that kind of selection bias in looking at your results. Nonetheless, it avoids exposure to any other pharmacological agents. It empowers people, and exercise actually is usually both mood improving and psychosis reducing. So it's just, as a standalone intervention, a great recommendation. Again, usually better to go beyond recommendation, usually to figure out a way to make it a plan and to set up systems whereby people can be encouraged to engage in it. I just restrained my impulse to do a snarky tangent. So there is
snarky tangent.
So snarky tangent. I mean, our drugs, our psychiatric drugs. This is at her invitation. Psychiatric drugs cause neurological side effects like dystonia or drug-induced Parkinsonism. And despite the fact that psychiatrists are not neurologists, my field has routinely stepped up and prescribed neurological medications, anti-Parkinson medications, to treat the side effects of the drugs that my treatments to treat the side effects that my drugs cause. Weirdly, my profession has decided that it's not going to engage its residents in becoming proficient in the use of diabetes medicines or weight reduction medicines. So we're prescribing these medicines right and left, which cause spectacular weight gain and all manner of health risks associated with it. Yet we don't train our residents to prescribe metformin or liraglutide or do other sorts of things. This is bizarre to me, and is a great deficiency in our current thinking and training. So psychiatrists tend not to step up and prescribe metformin along with the Zyprexa because they simply aren't trained to do that, because that's not a psych drug, and that's, as I said, unprecedented. Usually in medicine, you break it, you buy it applies, so we ought to do that too in our profession as well. And why I get snarky on this is because there are drugs that actually work. The politics of drug approval are such that Eli Lilly is not going to sponsor studies on metformin to prove that it can reduce the weight loss risk of Zyprexa, because it acknowledges that weight gain is a big problem with that. And the maker of metformin, well, metformin is generic, so there's no impetus to develop it. The maker of liraglutide, Saxenda, or please tell me on the other brand name, Saxenda, Victoza. The maker of those brands is probably not going to want to sponsor a study for its brand to be used as a treatment for schizophrenia, because it sort of tarnishes the image with the stigma of mental illness. So there's not a shortage of evidence to support the efficacy of drugs, adjunctive drugs for weight loss control. But there's not a corporate sponsor and a dissemination apparatus behind that. So lots of these findings are kind of unknown. Pharmacological inventions, there's evidence for efficacy, and the best evidence is with metformin. There's not as much, but still reasonable evidence for topiramate. There are some drugs which were specifically marketed for, well, at least fenfluramine and sibutramine were marketed for weight loss specifically, but those have been pulled from the market. Reboxetine is a selective norepinephrine reuptake inhibitor, not available in the United States. So we're left with two medicines, metformin and liraglutide, with reasonable evidence, and those are used, as you know, in the treatment of diabetes. We have topiramate, which is used in the treatment typically of seizure disorder, but it has, I'll explain, some benefit. And I don't think I'm going to talk about in this slide deck, but melatonin actually has a few interesting studies suggesting possible benefit, and there's a drug which is a dubious regulatory status. It's a histamine, it's a prohistamine drug, and those who are highly motivated, I believe, can get it somehow. But as I said, it's interesting, not tremendous evidence. Metformin, Actually, lots of evidence. Metformin improves insulin sensitivity, decreases gluconeogenesis in the liver, actually suppresses appetite, and there are studies in which, aside from any diabetes, with no diabetes present, people with obesity on metformin lose weight. This is another of the same kind of graph showing the results of meta-analysis, same rule. The big vertical line around 0 is the benefit or lack of benefit. Every mean, which is the diamond on the left side, is favoring efficacy for metformin. The horizontal bars are the confidence intervals around the mean. So if the horizontal bar doesn't touch the vertical line, that is that's the definition practically of statistical significance. So lots of significance, evidence for significance, and putting this in other ways. For treatment of established obesity in antipsychotic medication individuals, the number needed to treat for metformin is 3. That's a very low number, suggesting high and robust efficacy at reducing weight that has been caused by antipsychotic medication. And a number needed to treat to prevent is 10, which is not shabby, and certainly brings to mind the possibility, it's a reasonable consideration to counsel people at the very beginning, before they take the first dose of Seroquel or Zyprexa, about starting on metformin to try to prevent weight gain. So it's a very, very worthwhile drug, and psychiatrists, in my view, ought to be doing this like at the beginning. They ought to be comfortable prescribing it. Many of them are not. So people who are not, people who are in general medicine, I would love to invite you to be proactive in working with your patients to consider metformin, possibly liraglutide, as I'll show later on. Metformin as well has some interesting other side effects. These are not a lot of data, but they do suggest that metformin, for reasons I actually don't understand, may reduce prolactin, which becomes elevated in the use of antipsychotic drugs, and as well with normalizing hyperprolactinemia. Women who lose menstruation will regain regular menses when treated with metformin. So topiramate, I think folks are really familiar with this because it's fairly widely used in neurology and not infrequently in psychiatry. Although psychiatric uses for topiramate are, I think, entirely off-label. It is, by the way, a really ineffective medicine for bipolar disorder, even though it's an anticonvulsant. It tends to have a very interesting signal for helping people who have alcohol use disorders to become more successful at being sober. Topiramate, to the extent I use it, is oftentimes as a way to reduce mood reactivity in borderline personality disorder. It's one tool, so I use it sometimes for that. And topiramate has a very, very, very well-known side effect of appetite suppression. So that underlies the rationale for giving it to people on antipsychotic drugs who are experiencing or may experience weight gain. Topiramate in that population, or at least let's talk about topiramate in people with schizophrenia who are experiencing antipsychotic-induced weight gain. Topiramate does appear to help with the weight gain, primarily through appetite suppression. Topiramate is a mixed bag. There are some people with schizophrenia who, when taking topiramate, will have a further reduction of psychotic symptoms. So it can be a useful therapeutic adjunct. However, there are some people with schizophrenia who, when given topiramate, will have a worsening of psychotic symptoms. And there are reports of brand new psychosis happening as a result of topiramate. So it's a medicine that I use, but I use with great caution. And if I start somebody on it, I will watch them like a hawk to make sure that it's not going to make things worse. I personally don't use it as a weight gain mitigation strategy because the other symptom of topiramate, the well-known side effect, is reducing cognitive acuity. So it reduces processing speed and memory and so forth. Nonetheless, it's out there, it's known, and it's certainly worthwhile to consider. Liraglutide is a more recent medication, and like Wellbutrin, like bupropion, which went under the name of Wellbutrin for depression and Zyban for smoking cessation, liraglutide goes under two names, one for diabetes and one for weight loss. Interestingly, liraglutide has FDA approval for the treatment of obesity. There are really two papers in the literature looking at liraglutide and antipsychotic-induced weight gain. One was non-blinded. The other one, the results I presented in this slide, was double-blind, placebo-controlled, and they found on average loss of 12 pounds in just 16 weeks of treatment. This is actually the largest effect size that I've seen for any adjunctive drug in antipsychotic-induced weight loss, or in the treatment of antipsychotic-induced weight gain. So it is worthwhile to consider. As I said, psychiatrists are almost never going to prescribe this because this is not something we get trained in, but folks who are more comfortable, who see people with diabetes probably are familiar with this. So general practitioners should include this in the considerations of treatment for antipsychotic-induced weight gain. I know of people with clozapine who have gained substantial weight, who have taken their glutide, and it really has been miraculous for them. So it's worthwhile to know. Regular monitoring is important. The bottom line of this, I took away the table. I was going to show you the diagram of recommended intervals, but essentially every visit a person should have a weight. There have been anecdotally, well, at least at a conference I attended, there was a poster which showed simply showing somebody a graph of their weight in the clinic visit actually can help them to bend the curve toward mitigating weight gain or promoting weight loss. So you don't know it until you measure it. Your patients might know it, but you as a clinician might be less aware unless you actually look at it every time. And I think, and here's another story. I sent a poll out to a large number of first episode psychosis treatment providers asking, like, what topics would you like to see covered? Here's a box, tell us what you'd like to see, and here's like 20 topics that I can think of that you might be interested in. Please vote on which ones you would most like to see. Managing antipsychotic-induced weight gain didn't make it to the top 15. So I again, snarkily said, I guess it's not a big problem if you're not the one gaining the weight. So I think, measuring it every time helps you to keep on board. And this is, I get passionate about this because this is a preventable thing. This is something that we can actually manage. It's just that this is a kind of silent topic, and it's silent because antipsychotic drug makers don't like to highlight that risk, and those that make, if you will, antidotes don't really get into that business. So the literature grows, but it's in journals that hardly anybody reads. So here we are. Thus, that's the end of what I have to say. We'll, I guess, have brief questions and talk about case.
Yeah. Any questions? Yeah, well, we do have a couple people that have joined us since Eric started talking. So those who have joined us, maybe you can introduce yourself, and if you do have any questions at the time. Amy?
Hi, I'm Amy Lackroth, a pediatrician in Canton, Ohio. I don't deal with a lot of kids who are on these medications, but I do have one that was put on Abilify that had a big weight gain and probably improperly put on Abilify by a nurse practitioner who was really not qualified, nor did a thorough enough assessment of the patient. So trying to work with the patient on that.
Yeah, Abilify in particular is promoted nowadays as an antidepressant or as almost like an antidepressant. And actually, to be fair, it actually does a good job at treatment-resistant depression. But the idea, the promotion of it as a depression treatment leads to its broader use. And interestingly, as I said, in children and adolescents, the weight gain is much higher risk than you see in adults. And I hear that story of Abilify causing tens and 20s and 30s of pounds of weight. I hear that all the time. The second thing, interestingly, is that side effects of weight gain and side effects of tardive dyskinesia are more common when antipsychotic drugs are used in the treatment of mood disorders than they are in the treatment of primary psychotic disorders as well.
Interesting. Interesting. Just for my own edification, this patient was placed